Thanks, Karim. Good afternoon, everyone. I was actually going to do this presentation in one of the Hindi languages, but Sanjoy has blown my cover, so I'll persevere with English. Some of you would have come across this title called Where There Is No Doctor, which was a title of a book which was very popular. And then following that, there was another book which is called There's No Psychiatrist. So while I'm not planning to write a book, I certainly have stolen the sequel and put the title of my presentation, which is Where There Are No Smoking Cessation Counselors. What I'm going to do in the next 10 minutes is give you a very brief overview of the problem that my team and I are trying to address and the solution that we have in mind. Over the last few years, we've been collecting evidence to support and make that solution viable. So I'm going to present some of that data. And then trying to put that into policy and practice and trying to create an impact. So some of the examples of that. And throughout that process, there's several lessons that we've learned, and I'm going to highlight some of those lessons and conclude on that. Before I do that, just to acknowledge that the work that has gone in is a collaboration between different teams across many countries and also funded by a number of funders, including Wellcome Trust and CFH. So thanks for that. I'm a respiratory physician, and when I came into public health, for me, the natural area to address was tobacco. And it's always, although I've been working in tobacco control for a number of years, but it's always shocks me to remind myself that a sixth of the world population consumes tobacco, and every other person who consumes tobacco is eventually going to die of tobacco. So that's 50%, what we call in epidemiology as a case fatality rate. That's quite high. And still, we are in the situation that tobacco is still very common, and particularly in low and middle income countries where 80% of tobacco users now reside, unfortunately also focus of tobacco industry, marketing, sales, and unfortunately policy interference. I'm going to pick up a country that I was born in and where I'm doing most of my work. It's in Pakistan. It's home to 15 million adult tobacco users. Whether it's in Pakistan or in the UK or wherever, we've got a number of policy instruments that people have used over the years to try and address tobacco. One such policy instrument is taxation, increase tobacco price, make it unaffordable, and therefore people will be discouraged to buy it and continue to use it. The other instruments are banning advertising, promotion, sponsorship of tobacco, making smoke-free legislation, and so on. But people who use tobacco and addicted to tobacco, they need help. And those people, if you ask them to quit on their own, they're not going to do as well as if you offer them support. And the support that there's plenty of evidence, mostly from the UK and the US and other European countries, that if you offer them behavioral support, adding pharmacotherapy to their behavioral support, they do far better than if you leave them alone and ask them to quit on their own. So you would expect that we should be able to offer this evidence-based treatment to a vast majority of smokers. But that is not the case. Certainly in the UK in the last 20 years, there has been a transformation because of smoking cessation services, and a lot of people have been offered. And if they want to quit, they have access to smoking cessation counselors and evidence-based treatment. But that has not been the case in a lot of developing countries. So I'm going to pick up the case of Pakistan, but that is no different to a lot of low and middle income countries. So this is survey data. It's a nationally representative data that was collected as part of what we call as Global Adult Tobacco Survey. And in this survey, I don't think it's going to show that well, but in this survey, everybody who uses tobacco, and the survey splits into smokers and smokeless tobacco users. So smokeless tobacco users are kind of a category of tobacco users that use a form of tobacco that it's not combustible. So what we found out in that survey, that almost half of everybody who was consuming tobacco, they had a visit to a healthcare professional in the last 12 months. And what happened in that visit, that only a minority were actually asked about tobacco use, were given quit advice, and a very few number of people were given counseling or behavioral support therapy. In fact, probably 1% or less than 1% individuals. So out of all the smokers, when we ask them if they have been offered any treatment, it's only 1% or maybe 2%. Now that would be scandalous if we talk about cancers or diabetes. But nevertheless, as I mentioned earlier, that 50% of people who use tobacco are killed as a result of tobacco use. So that's quite shocking. But this is the treatment gap that we're trying to address. Now, what is the solution? So of course, countries like Pakistan do not have the infrastructure or the finances to offer smoking cessation services like we had, at least in the recent past in this country, although there have been cuts and a lot of services have been rolled back. But nevertheless, people have had that opportunity. Unfortunately, that is not the case in Pakistan. So what is the solution? Solution, in fact, comes from one of the public health systems that does work. So I'm going to make a case of focusing on a high-risk group, which is patients with tuberculosis or patients who are suspected of tuberculosis. So this is a high-risk group, and I'm going to give you 5 arguments why we focusing on this group could actually pay a lot of dividends in relation to offering treatment for smoking cessation. The first one is people who've got tuberculosis, they've got twice as much smoking prevalence as general population, so you're clearly hitting a lot more smokers with offering treatment to this risk group. Plus, when you offer treatment to people with tuberculosis, they're more likely to quit than general population. So this is a trial we conducted a few years ago in which we found that whether you offer counseling with some pharmacotherapy or without, you have 8 to 9 times more chances of getting that person to quit if you offer them nothing. And that's quite a lot because the best evidence for offering that to general population is only 2 to 3 times higher. So 8 to 9 times was quite significant. So not only people are more likely to smoke, but they're more likely to quit if you offer them treatment. And it's cost effective, it's cheap. $10 per quit was the assessment that we made in our study. Besides, you're not just preventing chronic diseases by getting them to stop smoking, you're also influencing their TB outcomes. 20% of TB deaths occur because of smoking, and hence, this is the study that we're doing at the moment, that if you offer them smoking cessation interventions, they're very likely to prevent deaths from TB. TB is still quite a deadly disease. About 1.5 million people die of tuberculosis, and hence reducing or making a dent in TB mortality through smoking is quite a welcome opportunity. And the final logic is that we have a program called Tuberculosis Control Program, which exists in a lot of these countries, and it's quite functional. So you don't have to employ a new health workforce or put up a new system. You can use the existing system, and that's exactly the kind of work that we're doing with the support of various research incomes over the last year. So what are the recommendations that we made to the TB programs? The first thing is to make hospitals and clinics that offer TB services smoke-free, including asking about smoking status, advice and support in their routine monitoring systems, training TB health workers to healthcare professionals to offer smoking cessation counseling to TB patients, and including smoking cessation in TB supervision and monitoring. And the way we've done it, and this is again with the support of CFH funding and also GCRF funding, is to try and implement that both at the policy and practice level. So at the policy level, we worked with the national TB control programs and trying to make changes in their plans and in their future projections to try and include these recommendations into their policies, working with the provincial system, implementing that at the provincial level, trying to change practice of health professionals and managers, and trying to assess the impact of those changes. And because it's a more diverse healthcare system, and we also have a private healthcare system as well as public healthcare system, so a colleague of mine is working with a private healthcare system in Pakistan, which is Indus Hospitals, to try and do exactly the same. And we also work at international level, so working with WHO and UNDP, who've recently issued this policy brief on integrating tobacco cessation in TB. Our work is cited, and we're working with them to try and get that into practice. So what have we learned? I'm going to use a framework that we use in implementation science called Paris Framework. What it basically says that if you want to implement evidence into practice, it is essentially a sum of some of the key characteristics of the intervention or innovation times plus the characteristics of the recipient and also the context. But that's also influenced by the facilitator. The facilitator is usually the implementer. It's their characteristic as well. So I'm going to give you 4 lessons on that framework that we've learned. The first one is facilitator need to be engaging, and true engagement, it's not tokenistic. It's real engagement with the policymakers, with the patients, with the non-governmental organizations, with the kind of community voices that Sanjoy was talking earlier. Adapting the intervention to the local context is key. If you look at, we started from using the NHS smoking cessation intervention, but if you look at it now in Pakistan, it will look very different because it's gone through so much adaptation, so much modification to the local context. Understanding and addressing the motivation and capability of the recipients. And while we talk about patients, but also health professionals, you're not going to train people unless you understand where their motivation lies and where their capability lies. So understanding that and trying to modify your training programs accordingly is a key. And finally, perhaps the most important is aligning your work to the program's priorities and helping to refine systems to implement change, because just training people or offering them some materials is not going to do anything unless you actually embed it within a system through working with the system and refining those changes. So the conclusion of our work so far is that offering smoking cessation intervention to TB patients makes a lot of sense based on the evidence that I presented. Given support, TB patients will quit in very high numbers at a very low cost, and embedding these interventions within TB programs is the way forward, albeit challenging and needs political buy-in. And finally, I'm a great advocate for implementation science, which is helping us to study how to scale up and sustain these cheap and cost-effective interventions within the system. Thank you very much.